Okay, I think we'll get started. Good afternoon and welcome, everyone. Thank you for joining us today. My name is Erin Medlin, and alongside Mark Einstein, Amy Ciros, Sherry Ampere, and Dee Spraccio, and all members of the SGO Communications Committee, we are here today to jump into our presentation, Ready for Prime Time, an abbreviated jumpstart to media readiness and mastery. This session is designed to give SGO members tools to be stronger communicators during media interviews. We will feature case study video clips, hear examples of media engagement gone awry, and introduce 6 communication strategies: the bridge pivot, flag refocus, block deflect, personalize, acknowledge, and broaden strategies.
So use your communication skills during this education forum, and we encourage you to tweet your thoughts about this presentation, hashtag SGOMTG, and hashtag Patients Purpose Progress. I think we should get started.
Okay, let's do it.
We're going to have some opportunities also to have some in-person audience participation and some Q&A after we do a number of different other things to prep all of you.
Yes. So thank you again to our presenters. We have no financial disclosures, and we will not be discussing unlabeled or investigational uses of any pharmaceutical products or media devices. A few special notes. In today's media landscape, there are a variety of mediums and outlets health professionals may engage with in interview format. During today's presentation, we will specifically be providing helpful strategies on tactics to utilize during oral interviews with television, radio, and print reporters alongside podcast hosts. Some interview strategies and tactics may be included for interviews that require in-person or on-set interviews or video conferencing such as Zoom, Teams, whatever your conferencing outlet may be. Most strategies and tactics discussed today will prepare individuals to answer challenging and timely topics and are positioned to assist in situations where you may feel on the defense. We are going to specifically focus on these 6 communication strategies. The first being the bridge and pivot. What is the bridge and pivot? You may use this when an interviewer or a fellow interviewee is asking you to speak beyond your personal bounds. You may want to reframe what is mildly inaccurate or off topic, and you feel like you need to course correct in this setting. An example of how something like this may go: this is not my personal area of expertise, but what I can tell you is X. What I'm hearing you say as the interviewer is X. What we'd like to see is Y. That is a valid concern. But another concern I have is X. You can see where there is a bridge, but a pivot. We're course correcting and moving the direction that we as the interviewee want the interview to go. The next strategy we'll be focusing on is the flag refocus. When you may use something like this. This is when an interviewer is attempting to get an interviewee to disclose information that is controversial, maybe private, maybe not for public consumption, or emergent. These may be political topics, for example. This may also be when an interviewer is prodding at an issue and you want to refocus to the area that you want to really highlight. This is maybe also when an interview is running off course and you feel you need to course correct to get to the heart of the issue that you were asked to speak about. You may also use this when you feel threatened to end the conversation, but do recognize that you need to redirect the conversation as well. Examples of how something like this may go. The heart of the matter is X. This cannot be confirmed, but what we can note is that's not completely accurate. While that you said is accurate, what needs redefining is Y. The third strategy we're going to focus on is the block deflect. When you may use something like this. When an interviewer and a fellow interviewee leads with information that is not rooted in fact, information that is based largely on opinion or is speculative. You may also use this when an interviewer or a fellow interviewee provides outdated, inaccurate, or exaggerated information. You may also use this when you need to shut down the conversation and you don't want to continue the conversation. Examples of how this may go. We cannot speculate about that. That information is distorted or out of context. I will not put words in their mouth because that is unfair. What we have here is a discrepancy between correlation and causation. The fourth strategy we're going to learn to utilize is personalize. This is when you want to elicit a greater emotional response from your audience in an otherwise dry or overly scientific conversation. You may also want to connect with a consumer, generate awareness, get consumers to take action, increase donations, etc. Something that we may use a lot in our everyday communication. When you were asked for a personal experience or testimony, how examples of this may be, in my experience, living with cancer. Science says this, but my personal experience said this. I speak with families caring for individuals living with cervical cancer weekly, and they tell me. The fifth strategy we'll look at is acknowledge. You may use this when the interviewer or a fellow interviewee has different opinions from you. When you are interviewing with a reporter alongside a fellow interviewee who is speaking excessively or out of turn. Examples of how this may go. I recognize there are differing viewpoints. We are saying similar things, but in a different manner. It seems, I hear what you're saying, and I appreciate the perspective. My perspective is, why? And finally, we'll look at the strategy of broaden. This is when an interviewer or a fellow interviewee is focused on something minute in a research study. When the interviewer or the fellow interviewee is exaggerating the importance of something. When the interviewee or the interviewer or the fellow interviewee is missing a larger picture that is more relevant to the targeted audience. Or when the interviewer is pinning a small issue on you or your organization, but there is a much larger issue at hand. How this may go. This is a challenge many organizations face today, not just our organization. This is an enduring challenge, one that many researchers have struggled with for years. While what you are sharing is indeed part of the study, it is not the only finding or most important finding. All right, so let's see some of these strategies and actions. This will be mostly an interactive session with our other presenters. So to recap, these are the 6 strategies we're looking at. We are going to have our fellow presenters give some examples of interviews, and we'll point out some of the strategies used in these interviews.
So we'll have our folks will come up. I will be the interviewer. We're going to be taking topics that SGO has been asked to respond to from the media in the last couple of years. So these are real topics, stuff that some of you might have also maybe responded to in the media. Now, we've taken some of the questions maybe to some extremes purposely to show some of these strategies in action, okay? And we'll talk a little bit about them, and we'd certainly love to get some feedback from the audience. So we have our experts here who will be the experts. I will be the, shall I say, the reporter asking questions, okay? We're gonna start with question related to the information that has come out with regards to BSO versus just a salpingectomy for risk-reducing surgery for ovary cancer, okay? So, and Dee will be our experts talking about this today, all right? So if my risk of ovarian cancer is so low, but my risk of heart health and bone health is tremendously high with early removal of my ovaries, why wouldn't all women just want their tubes removed?
I hear from women very often about the symptoms and long-term side effects of the early menopause caused by ovary removal, but these are valid concerns. Women, though, who happen to have a genetic mutation such as BRCA, have their ovaries removed because their concern is ovarian cancer. Many of these women have had family members relatives diagnosed with ovarian cancer, have seen the treatments, and sadly, some people have lost their lives to the disease. So these women have to have a conversation with their physicians about their particular risks and benefits of that risk-reducing surgery.
So you see what Dee did there with this sort of bridge pivot strategy. There was clearly an opinion from the interviewer that we should just get tubes removed because I'm worried about heart attacks and other things too. But this is a shared decision-making issue, and she talked about it being a valid concern, but the other concerns are, and she continued to go on like that. All right, so this is an example of using that in an interview strategy to sort of deflect away from what would be a very opinionated sort of report question. All right, so I got another question for you, Dee. All right, so so there are so many wonderful homeopathic remedies for menopause. I mean, I love taking primrose oil. Works for my mother. But it appears that nothing works for ovarian cancer. How do we compare menopause to risk of ovarian cancer at all?
Well, you know, there was a study done in 2021 that primrose oil actually reduced the frequency and intensity of night sweats during menopause. And we know it's very difficult for women to experience these early menopause symptoms when their ovaries are removed. In my case, I entered menopause after having ovarian cancer surgery. So not only was I dealing with menopause symptoms, I was also dealing with the side effects of chemotherapy treatments. So we know it's really important that a decision about whether or not you remove your ovaries is a shared decision made with you and your physician based on your personal risk and your family situation.
So you heard what Dee was saying. She actually used two different strategies there. She used a bridge pivot strategy of hearing what the consumer says and acknowledging that, but she also used a personalized strategy too, all right, personalizing it to her own experiences and personalizing to how that shares actually a very strong message. And sometimes we as providers will personalize things, well, in my experience with patients that I treat or something along those lines as a personalized message. All right, great. Thanks, Dee. We're going to move on to another topic. The next topic will be the association between hair straighteners and uterine cancer. Okay, that some of you have seen fluttering around in the media. Okay, and our expert Emmy will talk about this a little bit. All right, so Dr. Tiros, I got a question for you. Hair straighteners have chemicals in it, and many chemicals cause cancer. So why wouldn't hair straighteners also cause cancer?
So this is a really interesting question. So while it is true that many chemicals can cause cancer, it is also important to remember that not every single chemical is carcinogenic. So for example, hair straighteners contains a lot of different chemicals, which some of them could be linked to cancer in women, as mentioned in this publication. However, not every hair straightener contains the same amount of chemicals, and there could be some other risk factors, such as duration and frequency of use, and individual susceptibility, which needs to be accounted for. So there's clearly more research needed to confirm these findings in a different patient population and to really determine if the contribution of hair straighteners is really valid for health disparities in uterine cancer.
Yeah. So you heard what Dr. Tiros was. I mean, first, the question was rather pointed in an opinion that A equals B, B equals C. That doesn't necessarily mean A equals C. And we know that there's association doesn't always mean causation. And so she did a flag refocus. All right. She flagged it as yes, there are chemicals there. Okay, but really at the heart of the matter is these other issues that are there. Okay, and things that are not. It's not really completely accurate in that setting. Okay, so that's an example of a good flag refocus sort of message. So. All right, I got another question for you. So hair straighteners are toxic, and that's why the hairdressers have to use gloves. So why isn't this association not obvious?
Yeah, so the heart of the matter is that although some hair straighteners may contain some potentially toxic chemicals, there's no direct link between the use of them and the incidence of uterine cancer. So we have to remember that this publication is talking about an association. And we can just take a correlation as a causation. So at this point, there is no direct link established between the chemicals found in hair straighteners and the higher incidence of uterine cancer.
Right. So you heard Dr. Siros expertly veer the interview to where it should be going, okay? Talking about that more stuff has to be done and really do a refocus of like what was a obviously opinionated question thrown at her, all right? So we're going to move to another topic. Dr. Ampere will be our expert in the questions about treating pregnant patients who have cancers post-Dobbs, okay? So, and I'm sure that, and you saw flurries of various things that are happening, and some of you are in states that there are a number of questions that still remain. So, Dr. Ampere, question for you. So, if pregnant patients usually have early cancer, they likely won't die, so why would we even need to offer an abortion since they won't die of their cancer?
Well, you cannot say, predict, or even speculate whether someone with cancer will or will not die of their disease, even if they only have early stage. In addition, you don't know what they're going to be, the choice of treatment will be at that stage, and many of the options for therapy that we have are toxic to the fetus.
Okay, so there was a clear block deflect, okay? She talked about where can't speculate, about this. You can't speculate what happens with that cancer, what that cancer outcome will be, and then sort of refocused a little bit as well, okay? So I got another question for you. Since chemotherapy causes miscarriages a lot, why wouldn't we let nature just take its course instead of offering an abortion first?
That information is not completely true. Although some chemotherapy can or may cause miscarriages, not all chemotherapy causes miscarriages.
Okay, so another block and deflect in really trying to get the appropriate context of what it is and, try to redirect what can be a challenging question, okay? All right, another question. So moms who have cancer want to bring life into the world. Why on earth would we want to offer an abortion if she wants to offer life to give her hope?
I cannot assume to know what a mother wants, what she hopes for, or what is best for her family. That is something that needs to be done by her, a choice that can only be made by her.
So again, blocking and deflecting. And I think another point, a lot of times when we get asked these controversial questions, this is where if some of you are at places that have PR people or communications folks, it's important for, some vetting to happen. I mean, clearly the questions I was asking, there were some clear opinions and some clear directions that the interviewer wanted to go, okay? And, sometimes we have to vet these sort of things, and sometimes you might just want to say no comment, All right, so Dee, back to you. All right, we are going to talk about the experience of ovarian cancer due to genetic predispositions, okay, and family experiences, okay? So a question, and cascade testing and other things too. So a question would be something along the line, women do not want to suffer from menopause. So why do they want to choose an option of any type of risk-reducing surgery?
Okay, in my experience, the women who are actually being offered risk-reducing surgery have had family members who have suffered from the disease, or they themselves have a genetic predisposition to ovarian cancer. They are going to choose the option that is right for them. They'll weigh what their family and their personal needs are, and they are often willing to have the menopause experience early now as in order to put off having an ovarian cancer diagnosis later.
Right. So again, Dee did a wonderful job in personalizing this, okay, and using a personal experience to really explain the answer, and it actually elicits, I think, more of a response to the audience. So we haven't really talked more about acknowledge and broaden, but we're going to get back to our original questions. Emmy, we're going to talk about maybe something to use that you could acknowledge with. So we'll go back to the the use of hair straighteners in uterine cancer. So many black women use hair straighteners. Isn't this why a higher percentage of black women get uterine cancer than white women?
So I hear what you're saying, but this study does not specifically say that black women have higher risk of uterine cancer because of the use of hair straighteners. So what the study shows that the people who are using hair straighteners more frequently have a higher risk of uterine cancer, higher incidence. And when they looked at this patient population, 60% of these women reported to be a black heritage. So we really have to be cautious how we draw these conclusions. We really cannot say that the hair straighteners and being black women would have a relatively increased risk of using or getting incidence of high risk uterine cancer.
So Emmy acknowledged that there is a higher percentage of black women that get uterine cancer than white women. That's known, acknowledged that it's multifactorial, but kind of deviated away from maybe this association that doesn't have necessarily a causal association, at least not that we know of.
Yes.
Okay. All right. What our last sort of communication strategy, we'll talk about again the idea of cancer and pregnancy and post-ops. Okay. So Dr. Ampierre, is it easier to find a provider that can provide an abortion or finding a provider that can help with prenatal care?
Well, it's a very good question because access to care, any care, is particularly challenging, especially in populations that are uninsured or underinsured. However, since Dobbs, this has become particularly daunting in finding a provider that will provide a safe abortion. Okay. Imagine adding that to someone that, in addition, has a diagnosis of cancer, and the challenge is immense.
So she brought in this to a topic about providing care to women, safe care to women, all right? And that's an important thing that we all are as women's health providers or reproductive health providers to provide that safe care, all right? And then I acknowledged and identified the issues of challenges in a post-Dobbs world for finding the appropriate care. Okay, so which chemotherapies can cause miscarriage in pregnancy?
While it is true that some chemotherapies do cause miscarriages and are toxic to the fetus, our main concern is how are we going to provide access to women who want and decide that abortion is the right choice for them, especially after Dobbs.
So there was clearly a focus of that question of again getting at what is this misconception that every chemotherapy is fetotoxic, and so acknowledging and broadening this to a bigger the challenges at hand with providing safe care to somebody who is pregnant and who has cancer, which is I think something that I think many of us would probably try to focus on. So let's give a round of applause for our experts and the questions and examples. And these are just some ideas of how to do this. And obviously we know that it takes time to work on this, and over preparing for some of these things can be quite challenging, but using some of this stuff in your communication strategies can certainly help. Okay. Erin, you want to?
Yeah, and I think as the panel has highlighted, there are some key phrases that you can use from these strategies to really just build into your vernacular. This is a challenging question. This is an enduring challenge. I acknowledge what you're saying. From my personal experience, getting those in just on the tip of your tongue for each of those interviews may be helpful to you. Maybe.
Right.
Hold on. There we go. To go through a few more things in terms of media readiness. So some other tactics or strategies to really nail an interview. As we highlighted, you want to prepare in advance. Think about your story. What are you trying to convey to the interviewer? What is the message that you want to get across? Do you have a personal experience you're hoping to share? It is a good idea to memorize an overarching statement. For example, every 5 minutes, an individual is diagnosed with one of the 5 GYN cancers. I have heard Ginger Gardner say this probably 1,000 times. I've been on many calls with her as a communications chair, and she leads every discussion with this and at least says it twice in every interview. Think about what is your message that you always want to get across, and build it in. This phrase is also 14 words exactly. So 14-word statements or less are the comprehension span of most people. So having a tagline that is short, sweet, and to the point is memorable. Analogies can also be helpful. If you have an analogy that you can weave in very easily, that's easy to understand, it is an amazing communication strategy. You also want to be familiar with the news of the day. You do not want to be caught off guard. Knowing what's happened, read the paper that morning, look on CNN. If you did not know that Dobbs happened, that would be hard to be in that interview. If you had not read the New York Times on hair straighteners and you were doing an interview about uterine cancer and they brought that up, that would be a hard interview for you. You would need to utilize a lot of strategies on how to block and deflect. Also be familiar with laddering up. You want to get that overall message across. Cervical cancer is preventable. That is what you want the interviewer to take. That's the snippet that you want to be put in that paper or on that article. Practice those. Will make everything easier for you. You also want to be able to translate your science to the general public. You all do amazing work. You have amazing research. You have a message to get across. That can sometimes get lost in our use of words. We all use the word utilized. I think we use it. I use it too often with patients. Used. Used is a better word, for example. Methodology, appropriate for a scientific crowd, maybe not appropriate for your sister. Approach or strategy is a better way to phrase that. A phase 3 clinical trial. Your Aunt D probably does not know what a phase 3 critical trial is, but would know what a late stage research involving many people, that's explaining what that is. I used NGS, immunohistochemistry assay. Nobody knows what that is. Instead, something like, we found a way to use powerful profilers, really exciting new technology to zero in on changes in the gene that can tell us which treatment is going to help work best for this patient. It's a way to explain in everyday language that somebody can understand. A patient failed 2 lines of therapy. Do people know what a line of therapy is? Probably not. We tried 2 different standard therapies, but the cancer kept growing. It's putting in layman's terms, putting in terms that people who are not medical can understand. So really practicing and thinking, I'm explaining this to my 5th grade cousin of what is happening, and not to your colleague. Other strategies. Monitor your nonverbal cues. I like to talk with my hands. Probably talking like this with my hands is not effective, but maybe small gestures so you have some organic movement. Have good posture. Your mom and your piano teacher have been telling you this for years. Keep your shoulders up, your chin square. Make eye contact. You want to look engaged and not distracted during the interview. Try to breathe evenly. You are going to be nervous. Practicing some even breathing is going to help you get through the interview and look more calm, cool, and collected. You also want to project your voice. Vary your tone, and you want it to feel like a conversation and natural. We are going to look at some videos of our presenters here who have demonstrated interviewing in the real world. We'll start with the video of Emmy Zeros. I'm going to pull that up on the screen.
Okay, so let's get right into it. Cervical health. It's very, very, very important. How soon should we be talking about this?
So this is a hard question
Yeah.
because many of us would not like to talk to our daughters and sons about cervical cancer at early age. However, we recommend that you talk to your pediatrician and start these discussions early on, around age 11 to 12, because that's when we start giving HPV vaccination for our
children.
And when you're speaking about HPV, human papillomavirus, correct?
Correct.
So this is something, again, a vaccine for a virus, to keep the virus at bay, because it's the virus itself that leads to cervical cancer,
That's
correct?
correct, yes.
Can you explain that for folks out there?
Yes.
Yeah.
So HPV is a very common virus. It's found literally everywhere, and everyone who had exposure to sexual contact will get exposed at some point in our lives. And it is typically spread by skin contact and mostly genital contact. So it is very prevalent, and most of us will get exposed at least once or to one strain in our lives.
Yeah.
And then over time, it can lead to changes in cervical tissue, but it can also lead to vulvar cancer, vaginal cancer, rectal cancer, and even cancer in the mouth. So there are multiple other health implications to it. But many of these cancers are preventable if someone shows up for early screening.
And I think
go
that's,
ahead.
no, I was just going to say that is the beauty of this right now. This conversation is that we're talking prevention. Every
Yes.
time we have our
Correct.
friends from Roswell Park Comprehensive Cancer Center here, the main conversation is about prevention, because there's so much hope in that.
Yep. And people may ask, why so young? And you brought up a really, really, really good point on why you get the vaccine so young. Please tell everyone.
So the main reason why we vaccinate so early, because we want to prevent the first sexual intercourse and exposure. So we would like to train the immune system early on when there is no possible exposure. But also it's easier to vaccinate younger children. They just mount a more robust immune response and a stronger immune defense. So unfortunately, as we age, our immune system declines. And this is even visible after age 26. So the vaccination is recommended between age 11 up until 26, but currently is available up until age 45. So if someone didn't receive it up until age 26, you can get it until age 45, both men and women. But we just don't have such a great data on the efficacy after age 26.
Oh, okay. So the research is still ongoing, as it is in most things.
Yes.
So here's the thing. If it's not required, like you see, well, a lot of vaccines aren't 100% required, but there is a certain amount of vaccines that are required for children up until a certain point. But this is one you should definitely talk to the doctors about, correct?
Yes.
Because it is at an age where it's not in the regular course of vaccinations for children, correct?
Yeah, so it's not mandatory. So it's more like an opt-in vaccination. You can choose to give it to your sons and daughters if you would like to do that. Most pediatricians are highly encouraging parents to consider giving the vaccine. Again, this is so effective of preventing cervical cancer and precancer. We know that there is an 88% reduction of developing genital warts, precancer lesions, and cervical cancer. That is one of the best prevention strategy we have currently in healthcare to prevent cancer formation.
We also know that Roswell is very good at addressing disparities in our community. There is deep disparities in the Hispanic and the African American community. Can you speak to that?
Yeah. I mean, we definitely know that cervical cancer, precancers disproportionately affect more Hispanic women. And unfortunately, Black women have worse outcomes when they get cervical cancer. I think, many of this comes down to not having proper access for screening, not really doing a great job with our daughters and sons, educating them early on about the prevention strategies. And of course, sometimes when people show up for care, we try to do our best to deliver the same amount of care, but sometimes there's a mistrust with the medical community. So I think we do have to spend a lot of time educating our patients to make sure that they understand the importance of regular screening. So we're not just talking about vaccination, but also annual pap smears and HPV testing that is available for all women, which again is another very effective strategy for cervical cancer prevention.
Yeah.
All right, so we're going to break it down to nuts and bolts right now. People don't like to hear this, but how deadly is cervical cancer? What should people know about this cancer and how severe it can be so that prevention seems like a no-brainer?
Yeah. So this is one of the most common cancers worldwide. It's about the 4th leading cause for women's cancer death worldwide. Again, in the United States, because of the better and stronger healthcare system, women go for screening more frequently than in some low-income countries. But we still have about 14,000 new cases annually, and about 4,000 women die from cervical cancer in the United States. And all of these are completely preventable, or almost completely preventable. So I think the message here is that if people get the vaccines early on, the risk of developing precancer lesions is extremely low. Regular screening will definitely catch the cancer cells early on, so you will prevent the bigger cervical cancer.
I don't want to embarrass our colleague, but I will. So just to comment on a couple things, and you could see just the expertise. First, in the engagement, in the acknowledgement of the questions, the eye contact, the enthusiasm. I mean, these were all kept throughout the whole interview, even your posture. I mean, very, very efficient, very good. I appreciate that. Yeah, no, it's good. I know. You hate hearing yourself on TV. I know. I hear you. But, you know, some things, you know, first and foremost, you know, we are the experts. This room is the experts in, you know, the specifics, the nuts and bolts. And as what Erin was saying before about really sort of dumbing it down a little bit, you know, to the elevator talk, you know, she said like mouth cancer, or, you know, you don't necessarily want to say anus, you know, on TV. You said rectum. You kind of kept it simple, you know. And, you know, even like that last question, which was a very targeted thing about how cervical cancer is like aggressive and people die. It was a complete redirect. She did not answer that question, if you noticed, all right? This was a complete refocus. She talked about how it's a preventable disease. She talked about if it's picked up early, it's survivable, but she didn't talk about it, you know, being a deadly cancer, which was what the question was, you know, and because we know in generally we pick it up early or we could prevent it and it's not a deadly cancer for the most part. So you know, you saw a lot of these wonderful tricks, you know, being expertly woven in to how, you know, some of the questions really needed a lot of redirection. So great job. Yeah.
A great job. You may also have heard some other things. She had some good one-liners. 14,000 women are diagnosed with cervical cancer in the year. Those little facts that you can just spew off in there are going to be picked up as quotes, and you want to be accurate and have those on ready at hand as well.
To that point, that 14-word rule is super critical, and I think this is one of the challenges that many of us in the room have, whether you know it or not. You probably are speaking run-on sentences in your conversational talk all the time, okay? And it's very hard for us to really keep it into snippet type of stuff. But if you start talking about statements that are like qualifiable statements to a reporter, they could take parts of that statement out. I mean, I've been misquoted on Fox News. I remember having an interview where I was being asked about the appropriateness of mid-adult women getting vaccinated for HPV. Okay, and this was right when it was being discussed at the ACIP. And I said something along the lines of, well, our focus has to be on making sure that young women get vaccinated, and it's really important. And I went on in this sentence, in a very run-on long sentence, to say something along the lines, it's not cost effective to focus on the mid-adult women when we really have young women that we have to point out. And, you know, my quote was, Dr. Einstein doesn't think it's cost effective, for something like that. You know, that's not what I said. It was a long, drawn out, qualified statement that was taken out of context. So this is, I think, one of the hardest things to do is like keep it simple and not too long, and keep those words short, sweet, to the point.
Yes, thank you. We are also going to see a video from Sherry Ampere as well, and when she was on the CBS Evening News.
Here at Centro Medico, the island's largest hospital, ambulances arrive, but not everyone gets to go inside. Triage tents have been set up on a driveway because of spotty power and air conditioning.
How long have you been here?
I've been here for 20 years.
Have you ever seen anything this bad?
No, nothing this bad ever.
Dr. Cherie Umpiere is the head of obstetrics and gynecology.
There have been multiple home births, people that would not ever in any modern day give birth at home. People that have previous C-sections, previous with multiple medical conditions.
Who's delivering them?
We don't know.
Dr. Umpiere is trying to cope with limited operating rooms, spotty lab support, and dwindling supplies. One bleary-eyed resident had just finished a 30-hour shift.
But we used to work. I can see the volume of people increasing every day, and people that are not from our clinics, people that are just saying, you know, I can't find my doctor, will you take care of me?
It's great. A couple of things that you may have noticed in that. She did a block. I can't speak to that. I don't know who's delivering these women. She's not going to say something or speculate about what's happening. She made great eye contact. Her statements were very short and to the point. There's variation in her voice to get the point across. All great media strategies. Okay. Few other things to take note. During an interview, if you are speaking on the behalf of SGO or FWC, you are a representation of this organization. Everything you say reflects our organization. If you're speaking on behalf of your institution, another organization that you work for, you are speaking on their behalf, and everything you say will reflect that organization. Make sure that what you're saying truly does reflect that organization and is the message that that organization or that institution is trying to convey to the public. A few other little things. I think as we have all been on Zoom calls and team calls and everything over the last 3 years, we realize that lighting and environment is important. That if you are trying to look your best, you do want to look your best. If you are doing a lot of these interviews, maybe investing in that Amazon light is important. That raise your laptop so it's on even level and you're looking the best that you can. Maybe not have your laundry in the background. Getting that screen from your organization, that backdrop. You want to look and be able to convey the message that you want. You also want to be able to answer questions strategically rather than specifically. Come with your strategy. Come knowing what the message you want so you can essentially block, deflect, refocus, always bringing it back to what you are trying to say, not what the interviewer wants you to say. You can steer any interview in the direction that you want it to go when you master some of these techniques. You want to start and end a response to the point. I am so guilty of this. In sentence, in something like that. Your train of thought is going, you list several things and then you lose it and you just say in something like that. Reporters put that in print and you don't want to see that in print. And also don't get lost in over-explaining. Again, these 14 words are very important. Keep it short and to the point. You are experts in your field and probably could go on a full lecture about HPV vaccination. You do not need to. The public does not understand and they will not remember. Keep it short and to the point. You also want to maintain good boundaries. Assume that everything you say is on record. Everything you say in an interview can be quoted or misquoted or taken out of context. The cameras are always on as well. Every movement you make, everything is fair game to be part of that. And don't say anything that you would not want to hear back to yourself or in the print. Try also not to speak on what you do not know about. You can block and deflect. I don't know about this, but what I do know. Redirect the conversation. Come with that strategy. Get back to the point. Also be prepared for that question at the end. Do you have anything else you would like to share with us today? This is a perfect opportunity for your 14-word sentence to get your point across. We represent the Foundation of Women's Cancer. I often say something along the lines of, I encourage everyone to look for resources by visiting foundationforwomenscancer.org and continue our support.
If anyone has any questions, please go to the mic. I did want to highlight a couple things that Erin had said. If you have points that you want to make and they're trying to refocus, sometimes you go into these interviews with having, what are those 3 points that you want to somehow weave into there? All right, by bridge refocusing it into those points, it really does help to have an idea of what those 3 main points are before you go into that interview, right? What are you trying to get out there? And if you are given that opportunity to say, what else do you have to share, that you're ready with a statement that might either allude to the institution you're speaking for or one of the major points that you're speaking for, but have that sort of in your back pocket, okay? Just preparing a little bit mildly. I mean, you know more about this topic than anyone that you're going to be speaking to, and sort of keeping that simple really truly does help with that. And I think you've seen a lot from seeing interviews on the television screen and here interacting with just how to do these bridge pivots. For those of you who are just getting into this, I think it's easy to overthink this, don't. Like, I think, doing whatever affirmation that you have to do to say, I know this stuff really well, but I just got to make sure I don't like over talk about this stuff or over explain this kind of content. Okay. We're hoping that this will help you know just how easy and routine and that you're having a conversation with someone that might be a layman. All right. Not to over prepare for this kind of stuff, because I think the over preparation can also hurt you to some extent. Any other comments from the audience or any comments maybe from the panel up here?
I think from personal experience, these media requests are always very stressful. I feel like as physicians, we're just not really trained well initially to appear on TV. I remember as a new attending, we were asked roughly every 3 to 4 months to comment on something, and I just hated it. I was like, can you pick another attending? Like, why me again? But I think after a while, you get a lot more comfortable doing them. And I think the interview that I did at the Buffalo Morning News, the two ladies were really engaging, and they really made me feel like that we're just having a coffee discussion and just having that mindset that I ignore the cameras and I'm just going to focus on my two partners talking to me about HPV vaccination and prevention, and keep saying the same message again, that it's important to vaccinate, it's preventable, and important to do screening no matter what they ask, was really my thought process going into that. So I think, as Dr. Einstein said, it's really helpful when you simplify and then you have a few lines that you really want to communicate, and try to ignore the cameras and all the lights, and then just focus on the person in front of you talking to you.
And just to highlight what Emmy is saying, that her interview and Dr. Ampere's interview are very different, and the tone of those interviews were very different, and they brought a very different tone to each of those different settings. So whereas Emmy is at a mornings show that is conversational, educational, light, you're getting wetty and for breakfast. That is the tone of the interview, and that is the tone that she took. Dr. Ampere is talking about COVID and women dying and delivering at home, a very different message and a very different tone, and how their tone reflected that. So they are bringing the flavor of the interview and adjusting an interview style for that. And then, as Emmy is saying, you do want to be prepared. I think we all have watched ourselves on video and I personally am shocked and appalled when I watch myself on video that I sound like that. But get comfortable with how you sound and consider videoing yourself, watching other videos. If you're being asked on Cervical Cancer Awareness Month to give a talk, you can probably find something similar to Emmy's discussion on HPV and have an idea of what an interviewer may ask you and be prepared for that. I am currently watching the Netflix series The Lincoln Lawyer. And there is a woman on there who is wanting to be a talking head on CNN, and she has a whole media room set up so she can practice. You maybe don't need to do that, but can stand in front of your mirror and practice engaging with an interviewer, practice what that's going to sound like, record yourself on your phone, look at that video and see, oh my gosh, my hands are like this the whole time, I didn't even know, and have an idea of what you sound like. Other questions, comments before we get to our last video?
I'm going to add something a little practical.
Yeah.
So, and it was brought home to wear solid colors when you're on camera. Don't wear polka dots and stripes. And we were having a committee meeting, and I wore a black and white striped shirt, and I was distracting myself with the lines going up and down. So that's just a practical piece of advice if you know you're going to be on camera.
So true.
Thank you. And we have a question from the audience.
Hi, this is more of a comment. I'm Terry Cornelison. I'm with the FDA. And it's wonderful to see some of my colleagues up on the stage there that I've known for a long time. I'm really pleased to see this topic at this meeting. I don't know if everybody else in the room understands this, but what they're doing up there and talking about is tremendously difficult, extremely difficult. And I've been through formal media training, and every single time I consider it like eating my vegetables. I know it's good for me, but I really don't like it at the moment. My message is this. Besides being prepared and whatever, from the FDA, our language is so scripted, it's been rewritten by lawyers. But when you know you're going to go up in front of a camera, if you have time, every organization that we work in have communications experts. And if you can seek them out and say, look, I've got this, can you practice? Many organizations, including hospitals, have media training set up, have contractors for it, and can really get you in there, because you would much rather make those mistakes in front of someone who's coaching you. And I've had some really mean coaches where I just totally shut down. I said, this interview is over. That's it. And they had cameras on and video, and I'm like, oh God, I'm out. You know, no mas, I'm out of here. But having gone through that, and folks who are looking to help you be your best by leveraging the gifts that you bring personally to the engagement, is great. And so I would just convey that message, that pull in these experts, use their expertise. This is a different skill set than the one that you're usually using. But again, I applaud all of you. What you have done is tremendously difficult. I appreciate that, and I'm really glad to see this topic at this meeting. Thank you.
Thank you.
Thank you, Dr. Cornelissen. And to your point, I think there's a couple of additional points that I want to extend on top of what Terry had to say, longtime colleague and friend, and I'm thankful for you being here. And well, you've been in the spotlight in many of your roles at the NIH and at the FDA, so if anyone's going to say that, it's going to be you. So thank you for being here. But, as a scientist, taking those things and putting in that 45-second elevator talk is critical. I say to my science mentees, it's part of your job. So do what you have to do, whether it be going to somebody that might be more media savvy, getting formal media training from the communications groups that you might have either at your institution, or seeking that out would most certainly be helpful. And I think the other thing, and that I want to expound on it, that I think you were sort of getting at, we all think we're not supposed to be on TV and we're not supposed to be doing this. And there's that imposter syndrome that happens when we're asked to be speaking to a reporter. Get over yourself, all right? You have gifts that you need to be able to expose to the rest of the world, and know that what your message and what you have to say is important to the lay public and important to others, and to try to actually not get in your own head about this, but to really try to leverage it and say, I want to try to get these messages out. There's a reason why you're being asked to talk about this specific topic.
Yes, thank you. Any other questions, comments? We are going to end with a video that was starting to run about the Spirit Airlines CEO and how he is going to talk about bad ratings but high occupancy on Spirit Airlines, and how he goes through that interview. We can see some of these strategies in practice again.
Spirit CEO Ben Baldanza and CBS News travel editor Peter Greenberg, welcome.
Thank you very much.
So when you know that you're at the bottom of the list, you simply say to them, I don't care, my planes are full?
Well, what we say is that we care about what our customers care about, which is price. And one of the things that Consumer Report survey didn't ask is, where do you get the lowest fare? And so they asked about leg room, and they asked about check-in, and they asked about bag fees and things like that. But the total price that customers pay on Spirit Airlines is less than they pay on anyone else, and that's why they love us.
But does that mean that you can't have customer service and low price?
We do have great customer service, because we give them the lowest price possible. Obviously not in terms of what they say in this survey. Well, again, if you're measuring the physical distance between you and the seat in front of you, our seats are tighter than the other guy. But customers care about price, and we allow customers to travel for a lower price than they can otherwise travel.
Could Charlie fit in those seats?
He could absolutely fit in one of our big front seats, which will only cost you $20 or $40 more.
No, he could fit in it, Peter, if he likes riding with his knees touching his chin, he could fit in. But Ben, I got to hand it to you for being here, because most CEOs in your position, if they had been rated the bottom of the list, they wouldn't say, let's go on CBS this morning. Most of them would say, I have a pedicure in Peru, rather than come.
No, see, I disagree with that, Ben, because I think they would come because they want to say we're full.
But let's talk about the list that are important. You're saying bottom of the list. but we're number one in margin performance for our investors. We're growing faster than any other airline in the U.S., so we're employing more people. We're the lowest fare in the industry. So we're number one in the things that matter most to our employees, our customers, and our shareholders.
But because we're rated so low, does it make you think, well, maybe we can give people some peanuts? Maybe we can give them a bottle of water. Do you think about that?
Do you think a bag of peanuts or a bottle of water is going to make you feel better about sitting in a tighter seat?
No.
What makes people come to the Spirit Airlines is that our average fare in the first quarter was $75. And we fly an average of 2.5 hours.
There you go.
And when you fly, where are you sitting, Ben?
You know, I sit in different parts of the plane, and sometimes when the pilots let me, I'll sit in the cockpit with them and talk to them.
Well, you're clearly doing something right, because as Charlie said at the beginning of the segment, you guys are always full.
But you know, the disconnect is, so many of my friends, who you might describe as elitist travelers, would say, Spirit Airlines, never again, and yet your flights are more full than any other plane.
Well,
that's the disconnect.
Well, everybody hates Walmart, right? But it's the biggest retailer on the planet.
Yeah,
right?
and in the end, what you want to do is get there fastest, on time, with safety.
That's right. True. And spend your money on something that's more important, like a gift for your spouse or a nicer hotel room or something.
Or orthopedic surgery.
That's right.
Just could say elitist friends, Peter Greenberg.
Speak for yourself. Speak for yourself.
All right. Nice to see you, Ben. Thank you very much for coming. You're a lot of fun. Peter Greenberg, always good to see you.
I was going to say, that is a great strategy of blocking, deflecting, and refocusing every time. He got to the bottom line that Spirit Airlines is the cheapest airline. Said it again and again and again, and got his message across, and came out on the other side looking good. I mean, I might fly Spirit Airlines after this. So I want to give some opportunities again to ask any questions, final comments. I want to thank our presenters for being brave and answering these questions. And being in the hot seat, Dr. Einstein for being such a rigorous interviewer. We want to thank you all for coming. If you have any questions, please do not hesitate to come and talk to us, and enjoy the rest of the meeting.
Thank you all.
Thank you.